got just under 10 minutes for questions or answers. Can you also join us on the podium, please? Any questions for any of our speakers? Yes, sir.
Great session. I just have a question for those who presented on venous stenting. We recently had a case with post-pacemaker ICD lead implantation SVC syndrome. So now, any of your experts could suggest, after balloon angioplasty and recanalizing, and this actually comes back, and the patient came back within 2 or 3 months, I think, and this has happened twice. So how do you guys manage this? And could you actually stent it? Imagine that there is also an ICD wire that goes into the RV apex.
So the level of obstruction is the SVC or the brachycephalic?
So that's the question. It is actually at the confluence of the SVC.
Yeah. So I'd start perhaps by answering that, and then we can go to the panel. There was a paper actually published in the late 90s from our group at the time, Stanford, exactly on those patients. And initially we were looking at the dysfunction or malfunction of the pacemaker. We didn't see any. So we would put stents right on top of the leads. The only complication in those situations, it makes retrieval of the leads, if you ever need to take them out, more complicated. There was no dysfunction, there was no problem, and the outcomes were the same as SVC, any benign SVC occlusion under those settings, because the main problem is thrombotic. And those are the patients with stent outcomes are slightly worse. Any comments from anyone in the
We had 2 of those cases. I'm a non-invasive guy, but I was involved in the care of these 2 patients. So the electrophysiologist actually did the procedure along with the interventionalist, where they came in, removed the lead, then angioplasty stenting, and then lead reimplantation through the stent. So it's, yeah.
And it's probably advisable to keep them on anticoagulation.
Yes.
Yeah, I would agree. I think, I've been involved with a couple of cases that way as well, and both of them involved, first lead extraction, stenting, followed by reimplantation. One of them actually was not a defibrillatory, but a pacemaker, and he was pacer dependent. So we had to first place an epicardial lead so that he could, be paced, because otherwise, when you took it out, that would be a problem.
Okay, well,
our experience has been the same. So it sounds like a consistent theme here: removing the lead, stenting, reimplanting the leads. We've done the same thing.
So just to complement that, we've done actually a large series of these stenting on top of the leads. There's obviously no one really knows, but you can if you need to, if the extraction is difficult. Yes, sir.
No.
When you stent iliac compression, and you have areas of dilation, like ectatic dilation or pre-stenotic dilation. I've had a patient just last week with 25 millimeter diameter, just behind the confluent. So how do you size your stent? Stent sizing has become a real issue. And do you are you worried about not opposing, the stent to the wall? Do you size to the ectatic dilation area? Do you extend your stent all the way to the iliac? Do you see remodeling in those patients?
Great question. Maybe we should start with you with that. So that is an interest. That's a common observation that in the segments upstream from an obstruction, you may see in a normal vein a dilation of the vein. That is not the normal size of the vein. Once you relieve that, size changes. Yes.
So actually you see that very commonly, that you dilate, then the stent, one especially proximally, does not oppose the walls. So remember, you are focusing on the stenotic segment, and it's why you oversize as much as you can. And in many cases, because the vein is not like the artery, it can have a different shape. This is a false picture, I call it, because if you take different sizes, there is opposition, but not all the areas. So just go to the area with the stenosis and don't worry about the rest of it.
Mahmood, I have a question for the panel about, interventions in general. You and I were chatting on the side that, socks don't help. Attract, some people like Clive Kieran and Susan Khan have floated statements that it's probably not useful. So none of the things that we do are useful, is what it seems like, right? So the question is, are we missing the combined, superficial and deep insufficiency that is making the results a wash. And, you see whether you take, Cavent or Attract, the risk for post-thrombotic syndrome, even in treated patients, is significantly high. And there is 2/3 of patients with DVT, according to Carmarota's report, have reflux. So if you're redesigning Attract or if you are on C-Tract, how are you going to,
That's right.
accommodate that?
That's a great question. The issue is, I think what we're missing is that we think of veins as conduits, like arteries. They're not. They're conduits and they're physiologic organs. And so they have capacitance functions, they have anti-reflux function, and they have conduit functions. And they're far more complex than arteries. And so we're sort of thinking along the plumbing. And that doesn't always, that's why a lot of our studies are negative, because we think of plumbing. But that's a great question. Great question. Yes, sir.
Not to mention, the hypoxia from central sleep apnea,
exactly
obesity,
right.
and, right heart failure and all those things too.
Well, thank you. My question is related to the last question the person asked, actually. If you're treating a May-Turner syndrome, the length of the stenosis is pretty short. And then there is a disparity between the size of the vein. There is an ectatic segment proximal to the stenosis, which is huge, sometimes 20 millimeters. And then there is a femoral vein or external iliac vein, which is probably 9 or 10 millimeters. So number one is the size of the stent, as you answered, I guess, appropriate. How about the length of the stent? Because we do see stent migrations. So should we oversize the length of the stent, and how much we should oversize the length?
The stent migration is more a feature of all stent than the nitinol stents. Of course, the sizing is critical in those situations also. It is philosophically, personally, I do not like to extend the stents beyond areas that doesn't need the stent. Whether that makes a difference in the outcome or not remains to be seen. But as Dr. Nazzal mentioned, once you stent those segments that are occluded, you find out that immediately the size of the vein changes. And it's not 20 millimeter or 25 millimeter in the segment proximal or upstream from the obstruction, but immediately it collapses. And we have examples of that. I mean, I can show you examples day after day on those types of situations. So we stay very disciplined in our stenting protocol and the sizing protocol. Don't be fooled by the dimensions of the veins pre-stenting, because that changes.
And a similar question, because I had one patient similar. Somebody put the stent in, and it migrated into the IVC. What do you do in that case? I mean, because it was very close, it was touching the filter.
Depends on the type of stent. Some stents are retrievable. Wall stent, you can retrieve it. Even if after it's fully deployed and out of your catheter, you can still retrieve it. Nitinol stents are very difficult to retrieve. So you have to be careful. Now, if the stent migrates into the IVC and you think there's an obstruction, causing obstruction to the contralateral side, some people put a kissing stent from the other side, and now there are reports of thrombosis on the contralateral side after stenting. So it does happen. The incidence is pretty low, but it can happen. So it all depends what things look like under those circumstances. Okay, guys, it's about 10 o'clock. Our session is over. The faculty are here. If there are any questions, any further questions, everybody's around. Just get a hold of them. Thank you very much for this.